Assalamu alaikum students. So this lecture is regarding circulatory shock. This is one of the last parts of circulation, the circulatory unit in Guyton physiology. And this has immense importance as far as clinical practice is concerned, as far as physiological concepts are concerned. And of course, the assessment is there. A lot of questions can be generated, and they do get generated for your professional exams, both MCQs, SCQs, and Viva. An important point that I'll be reinforcing, especially in the first 1/3 of the lecture, is the overlap of the conceptual construct of cardiac failure and circulatory shock. You will find a lot of overlapping in these two concepts, and I'll be talking about it in the following slides in my struggle to basically reinforce your concepts, the complex concepts of circulation, where things get integrated, where multiple mechanisms come together. That is where circulation is most challenging. And since now we are at the far end of circulation, it's customary to look at the entire picture, and that too in an abnormal situation. So if you can work this out, surely you can work out the normal stuff any day. Okay, so let's start the learning objectives. We'll be defining circulatory shock, its causes and types. We'll be explaining the stages of shock and each type of shock. Even the learning objectives, as you may note, are very similar to cardiac failure, and there's a very big fat reason for that. Okay, so what is shock? Circulatory shock. It is basically an inadequacy of blood flow, which is generalized. So it's all over the body. We're not talking about a specific organ. We're talking about all body. Generalized blood flow has become inadequate due to some reason, and such that the tissues they are complaining. Their needs are not being met. Okay. What are the manifestations of shock? So shock, basically, what do you see in a patient? You see symptoms and signs of impaired perfusion of the blood of the body tissues, okay? And mixed with that, you see body trying to get out of it, okay? So compensation, body's reaction to this insult. And this basically comprises of two main events, although there are lots and lots of events. But to summarize, the main two events are CNS activation and SNS activation, I beg your pardon, sympathetic nervous system activation and fluid retention. Remember that what I discussed in during cardiac failure are the three things: heart, circulation, kidney. Okay, and then you have a hovering angel, which comes to your rescue whenever you need it, and this angel is very fast in its action. That's the sympathetic nervous system. Okay, and the kidney plays its role by retaining fluid and trying to address the volume. This is short term, this is long term, right? Again, this is the same sequence that you saw in cardiac failure. So again, there are parallels here, which will be reflected in the following slides as well. Okay, the one thing that you now need to remember, and this is me building up on this narrative of cardiac failure / circulatory shock, is that your focus needs to be basically on arterial blood pressure. From a practical standpoint, i.e. from a clinical standpoint, it's basically the blood pressure that basically goes in cardiac failure and almost all of the circulatory shock scenarios. It's basically the mainstay is arterial blood pressure. Okay, keep your focus on that. So this will help you in the clinical side of things, and surely it will help you to make a mental picture as far as the physiology of these concepts are concerned. When you have cardiac failure, you have a drop in blood pressure. When you have circulatory shock, you have a drop in cardiac failure. Whether it's the initial response or the later on response, it gets involved. I beg your pardon, I said, did I say cardiac output? I meant blood pressure, arterial blood pressure. Okay. So in both conditions, basically the thing to look for, the thing to notice and make your focal point is arterial blood pressure. This all will start to make more sense to you. Okay. It's just the angle, basically, where the handle, rather, by which you disturb the arterial blood pressure. Okay. In cardiac failure, it's the heart, because it says cardiac failure, so it has to be the heart. However, in shock, you have both, taste of both worlds. You have cardiac involvement. You may have cardiac involvement, or you may not have cardiac involvement. Okay. Now, so this set of things is I've labeled it decreased cardiac output and decreased venous return, as opposed to not related to cardiac output or venous return. So this section you will see that it basically hovers around these two issues: decreased cardiac output and decreased venous return, which basically, if you remember, also get involved heavily in cardiac failure. Okay. So if the heart itself gets involved, as we said at the end of cardiac failure lecture, cardiogenic shock. So if the heart itself gets affected tremendously, the circulation follows it. And in this specific condition, it's called cardiogenic shock. So not only are we having cardiac failure, it has now proceeded to cause generalized hypoperfusion of the tissues, which we just learned is called circulatory shock. So cardiogenic shock is quite literally where cardiac failure and circulatory shock come together. Okay. Then you have obstructive shock. Obstructive shock is also related with heart, in the sense that if you have any sort of obstruction to the great vessels coming back into the heart, the superior inferior vena cava, or the pulmonary artery, which exits from the right ventricle, or the aorta itself, which comes out of the left ventricle. Any obstruction to these will obviously have a direct effect on the heart, and the heart will go into failure and eventually will trigger a systemic or pulmonary circulation collapse, which is referred to as shock. One other thing included in obstructive shock is cardiac tamponade, which basically is abnormally large collection of fluid inside the covering of the heart, the pericardium. If you have more fluid surrounding the heart, obviously it will have a physical compression on the heart and affect its functioning. So these are the causes of circulatory shock which are related to the heart. Okay. Now we are purely talking from the shock point of view. Then you have purely circulatory, quote unquote, circulatory causes. Any hypovolemia, blood loss, plasma loss, any sort of fluid loss, whether in dehydration, where you lose ECF volume to the extent that the preload is deficient. You will have circulatory shock, and the perceptive student will immediately connect this concept back to cardiac failure, right? Because the preload is the coupling factor, as we've discussed, the coupling factor between circulation and heart. So it's almost poetic to end this lecture series on the absolute interplay between heart and circulation, that we literally cannot speak about the circulation without mentioning of the heart, and we cannot mention the heart without circulation. So this is why we call it the cardiovascular system. So hypovolemic shock, from its origin, is basically a pure circulatory situation, which eventually then gives rise to decreased preload, after which the heart gets involved. Okay, so this is hypovolemia or hypovolemic shock. Distributive shock is again a circulatory issue, and in this we'll study two distinct entities: anaphylactic shock and septic shock. For now, all I'll say about this is that it's called distributive because while there is no loss of volume, however, there's massive vasodilation in both types of shock. So again, the preload drops. There is stasis of fluid in the periphery. The circulation sort of stagnates. There is no rotation of fluid. And of course, the tissue perfusion will be hit very hard, and hence the person goes into circulatory shock. Okay. So this bit here, the whole thing is basically related to anything which decreases cardiac output, either itself, heart, or via decrease in venous return, which basically is this. Okay, so this is a nice one single cover where again I would say the heart and circulation come together. Then you have independent issues like we again discussed this. There are conditions of thyrotoxicosis. This is hyperthyroidism. You'll study this in endocrinology, and beriberi, a vitamin B disorder in which the metabolism, the BMR, basal metabolic rate, goes through the roof. It's a very high demand of metabolism for substrates and oxygen. And obviously cardiac output, the heart itself obliges to a certain extent, but then, well, there's a limit to everything. The heart basically fails and the body then goes into a shock situation. So this can be played both ways. You can mention this in cardiac failure, and it also gets mentioned in shock, because when the heart fails, then obviously the circulation would fail. And then you have AV shunts, basically the blood shunting from the artery directly into the vein, bypassing the tissue. The tissue will sense that, you know, what's going on here. The perfusion will drop or be absent. The tissue needs will be there, which won't be fulfilled. And again, this is a circulatory shock situation. Okay, so now we talk about the stages of shock. Okay, so just like we mentioned the stages of cardiac failure, shock also has stages. One is non-progressive compensated stage, in which, as I mentioned, you have sympathetic nervous system activation, you have fluid retention, and there's much more actually which goes into play, and we'll discuss this in a bit. So the first concept that I would like to tell you is, in stages of shock, there is a nice full of hope stage called non-progressive or compensated stage, in which body itself comes out of, if you give it a chance, if you let the insulting event, you arrest that event. So if it's a blood loss, you stop the blood loss, okay, and then let the person recuperate. And these are strong mechanisms. They do take time. This obviously is a quicker one. This is the more long-term one, minutes to hours to even days, but it does get the job done. And you don't, basically the key word is, you don't need medical intervention in non-progressive shock. However, this now is a dangerous downslope. It's called progressive stage. As opposed to non-progressive, we have the progressive stage. You will need therapy at this stage. This stage also has a lot of mystery around it. Somehow things go out of hand as you go down the slope. So it's really the timeline. If the patient has not been, either the non-progressive stage wasn't enough because the insult was too much, or some other thing happened, somehow the person started to go into progressive stage. This needs aggressive therapy. And this stage, the good news is it does respond to therapy. However, without therapy, the shock simply progresses downwards, becomes irreversible, and then, well, then the inevitable happens, okay? All right. Then the final point is basically, there is a grayish area before death. It's called irreversible stage. Irreversible stage, as the name pretty much sums everything up. All forms of known therapy are inadequate at this point in time in saving the person's life, and it's really down and out. So basically, stages of shock have been nicely depicted in this particular flowchart. You have decreased cardiac output and or blood pressure. There's a compensated stage in which all sorts of acute and intermediate compensatory mechanisms try to do what? Address your cardiac output and your blood pressure. If this is not, this doesn't improve the whole situation, the person goes into progressive shock. As I mentioned, there's initial deterioration. You need intervention, transfusion, vasoconstrictors, cardiac stimulants, all sorts of things go into play just to get, again, the cardiac output coming back, the blood pressure rolling up. However, if this deterioration, and again, this is an important point here, this initial cardiovascular deterioration, if it was manageable in its intensity and was later on subsequently managed properly, then the day is saved. However, if the initial insult was too much and it was too much and the person actually came to you in a irreversible shock stage, then that's one thing. Or if it was manageable but it was not managed properly, then again you have both fates are irreversible shock, and you just cannot control your cardiac output and the plummeting blood pressure, which basically leads to a vicious cycle, which is called basically the irreversible shock. And the myocardial muscle itself gets injured. The tissues physically get injured by the lack of blood supply. They go ischemic. All sorts of toxins get released. Massive vasodilation ensues, and heart then gives way, and so does circulation, and the person dies. This is a nice overview of the whole concept. Of course, we'll be discussing details of each of this stage. Okay, now a description of various types of shock. We discussed hypovolemic shock in detail, and you will find this in Guyton as well. This is basically the mainstay of the entire chapter of circulatory shock. He discusses hypovolemic shock for the simple reason that this type of shock has been most studied. That's one point. Number two is that this is one of the most presented shock in the emergency. Okay, so the number of shock patients that you will find in your ER will be hypovolemic. Okay, so that's why this is properly researched and properly described. And in fact, a person who has not been told about the importance of hypovolemic shock, when he opens up Guyton and starts reading it, immediately after initial descriptions of general shock, the author just goes into hypovolemic shock and then keeps discussing hypovolemic shock for a good middle 1/3 of the chapter. And sometimes students basically lose their way into which is which. Okay, so this is again a hypovolemic shock. It's a type of shock, and all those stages of, say, irreversible, compensated, then progressive, and then irreversible stage, all of those stages will feature in this hypovolemic shock, as is the case with any other shock. Okay, it's just that since the two reasons that I gave, hypovolemic shock is the most studied and the most presented in the ER. Every stage of this shock is very well documented and very well described in undergrad books. That's why you will get all of the stages properly described upon this specific type of shock. However, I will again say that all shocks feature all those, or can feature all those three stages, and so on. Okay, the causes are pretty much predictable: hemorrhage, trauma, surgery, burns, loss of fluid, etc., etc. We'll be talking about this in a bit. Then this is a very interesting graph in Guyton that I truly appreciate. It sums up a lot of stuff in circulation, brings the two brothers together, cardiac output and arterial pressure. I would say brothers because look at the way the symphony flows from top to bottom. Obviously, it's not a nice symphony, it's a bad one. But still, the point is they play together. And you'll see probably the final discussions about cardiac output and blood pressure. You'll see how beautifully they are linked. Cardiac output being a cardiac function, and arterial pressure being a cardiac and a circulatory function. Okay, so again, the parallel of cardiac, heart and circulation comes into focus by this graph. Okay, so what is this graph? On the x-axis, you have a percentage of blood removed. So obviously, we're discussing hypovolemic shock. We are interested in what happens to the body, what does it do, what happens when you remove blood. Okay, so this is percentage, 10% removal, 20%, 30 and onwards, and its effect on cardiac output and arterial pressure at the same time, a percentage of normal. Okay, so we'll discuss it from here. You'll see that in the first 10%, basically, there is not much going on in terms of any reduction in arterial pressure or cardiac output. Okay, right after 10%, you'll see that literally cardiac output, it just dives till here. Then a final hiccup, a final recovery sort of is attempted, and then it crashes. Right? Remember, we are removing blood sequentially. So 10% was removed here, 20% was removed. So we are progressively decreasing ECF volume. This was done in dogs, I imagine. And basically, the cardiac output came down like this. However, you see the peculiar thing with the blue curve, the arterial pressure curve. You see a lot of struggle going throughout here. Actually, the whole thing is quite wavy here, basically. And this is what? This is your baroreceptor reflex trying to save the day. And it does. And you can see that the sympathetic reflexes basically work over time and above what they do for the heart. For the arterial pressure, they maintain arterial pressure for a longer time. So even at 20% of blood removal, you still have maintained your arterial pressure with no significant drop in arterial pressure, which is basically a big feat. And if there was a live class, I would give you a very hard time by asking you to explain this, which obviously I can't hear, the perils for a teacher. Anyhow, but look at the cardiac output at 20%. At 20%, there's a significant decrease in cardiac output. However, the arterial pressure is there. If you remember, arterial pressure is the product of cardiac output into TPR. Okay, so while the cardiac output is going down, the sympathetic stimulation is obviously trying to keep the heart up as well, but more clearly, it is trying to increase the TPR. Okay, total peripheral resistance. It's really vasoconstricting those arterioles to give you that every degree of arterial pressure that you require in this very, very abnormal situation where 20% of your total blood has been removed. Finito, it's gone out, right? But obviously, every good thing comes to an end. After 20%, it's just the volume is just too much for any vascular manipulation to artificially keep the arterial pressure up, and it goes down. It goes down almost as similarly, in a similar fashion, although even still higher, better in its deficit. Still, the shape of the graph is quite there. And then again, peculiarly, you see a final attempt, so to say, where the arterial blood pressure is trying to still bump up, but then it just crashes and joins its brother here on the x-axis. So what happened? Basically what happened, as I mentioned, the sympathetic reflexes fought bravely till this point, then gave way, arterial blood pressure came down, and remember, below 60 mmHg, what gets triggered? Which reflex get triggered in the acute regulation of blood pressure? If I hear CNS ischemic response, then bingo, you're right. This is actually the CNS ischemic response, giving the last ditch. It's also called the last ditch response, giving the last ditch that maybe the person survives. But since we are artificially removing the blood, or it can be mimicked in a real situation where there's trauma or a road traffic accident, as it usually is the case, where the blood flows out or is lost at a rapid rate, and there is no provision of an emergency aid like 1122 does not reach there properly, or 911 abroad. I don't know what the emergency services are called in the UK, but equivalent to 911. If they don't get there quickly enough and there's a massive trauma and a lot of blood loss, then a similar fate is followed in humans as well. Okay, so this is what this graph is all about. It's very nice. Do read it from Guyton. It's beautiful. It also says that basically sympathetics are favor, and this is what I like about this description, they favor controlling arterial blood pressure more than they favor saving cardiac output. It's a beautiful description of the preferential treatment that arterial blood pressure gets from the sympathetic saviors than cardiac output. And the mainstay is improving the TPR. And you know that TPR has no mention in the cardiac output. Cardiac output is stroke volume into heart rate. So there is no great mention or great effect of maneuvering the TPR on cardiac output. However, it's the better half of arterial pressure. So there goes. However, there's one mention, honorary mention for sympathetics. They do improve the heart rate, cardiac output by squeezing out blood from the veins, vasoconstricting the veins, and improving the venous return. So that's one thing that needs to be mentioned. Okay. So enough about this. We move on. So the non-progressive compensated stage, which are the compensating mechanisms, are this. So when I said cardiac factors and venous return improvement and all that, plus much more, this is that much more. We have discussed this bit, okay? The brain also comes into play. The thirst center, there's a thirst center which we will discuss in renal next year, inshallah. Thirst mechanism also gets triggered. ADH again is a part of the brain which releases ADH. We have mentioned this in the last lecture, antidiuretic hormone. It basically reabsorbs water. Of course, it's hypovolemia. You can put 2 and 2 together. You are reabsorbing water in this situation. It is always going to be beneficial. And thirst means you want to drink water. And if you have noticed a person with blood loss, his lips are very dry and he's looking for water. There's a technical reason for that, and you have read that today. The adrenal gland is very, very important. It's basically starts producing aldosterone in this situation, and epinephrine and norepinephrine. I need not explain to you what these are. This is the fight and flight that you have been reading in all your junior classes. Aldosterone, however, basically helps you to reabsorb extra salt and water, again, adding to the ACF volume and trying to save the day. The kidney will directly cause sodium and water reabsorption. Remember, sympathetic stimulation also activates tubular cell uptake of sodium and water, as we discussed in the last lecture. And it will start to decrease the urine output, trying to conserve as much water as possible. Even at the capillary bed, you have fluid shift in favor of adding volume to the circulation. So all of this goes into play in the non-progressive stage of hypovolemic shock, trying to increase, remember, trying to increase the ECF volume, okay, the initial insult. Okay, then if the person is in trouble, as I explained earlier, and goes into progressive stage, this is that vicious cycle. Remember, vicious cycle means positive feedback. So now you are looking for a positive feedback of cardiovascular deterioration. It's looks like an extensive flow chart, but it's not that bad. Look at the yellow stuff first, okay? So basically, there is decrease in cardiac output. Decrease in cardiac output will eventually lead to decrease in arterial blood pressure and systemic flow. And basically, this decreased cardiac output eventually will have an effect on cardiac nutrition itself. The heart will not be supplied blood to its tissues because of the decreased cardiac output. It will be so less against decreased nutrition to the tissues itself. So heart gets less nutrition, tissues get less nutrition, and then this third and very insidious development of intravascular clotting or coagulation. You must have read this under DIC, disseminated intravascular coagulation in blood physiology. Decreased cardiac output means the flow of blood has decreased, it has become sluggish, and hence it's prone to clot formation. Okay, this in itself directly causes a decrease in venous return. So this is out of the way. Now, decreased cardiac nutrition means heart will even further weaken, further decreasing cardiac output. So this is that. Okay. Now look at what the tissue nutrition, the decreased tissue nutrition, what does it do? It basically does a lot of damage. And this I will leave to your own reading. I'll look at the yellow stuff. Eventually what happens is, remember, this is the progressive stage and medical therapy can save this person. Okay. And as we move down and into the white stuff, this is basically, this means that this chap is not receiving medical attention or not enough of it. Okay. Only then you go down this very gray and black flow chart. Anyhow, so if there's a toxins which are released out of tissues, it's a bad sign. If there is decreased volume overall in the blood, it's a bad sign. If there's venous pooling of blood, bad sign, because massive vasodilation is a bad sign. It normally doesn't happen that way. If you have massive vasodilation, there will be involvement of the brain, and involvement of the brain itself is a very big red light, right? So release of toxins causes further cardiac depression by literally damaging the heart physically. It's a toxin, it's a poison, it's bad for cells. It's also bad for cardiac cells, okay? So this is very problematic. This also damages vessels, again, adding to the woes of this patient. Decreased volume will add to decreased venous return. Pooling of blood in the periphery will also add to the decreased venous return. And so the end point is a vicious cycle of cardiac depression, leading to further decrease in cardiac output and decreasing venous return, again adding to the woes of the heart by decreasing preload and further decreasing the cardiac output. This is a very nice description, and you can, if you can remember the major points, the main points of this, at least the yellow stuff, and as much as the white stuff in between, you're good to go in describing progressive stage in your assessments. Okay, then on to the irreversible stage, as the name suggests. It's irreversible. The cardiac deterioration which we set off in the progressive stage further continues, and now whatever you do, it's not going to help the situation. The cardiac and peripheral tissue injury, because of the toxins released, the injury is just, it's gone into positive feedback, and further decrease in the cardiac output and venous return ensue. Basically, the last flow chart is also applicable for irreversible stage. Just add increased arrows to every stage, and you will make the progressive stage into an irreversible stage. Again, intravascular coagulation worsens up. However, this is all present in the last progressive stage flow chart. This is an exception. So if somebody asks you, what is that one differentiating point between progressive shock and irreversible shock? It is this, basically. What is this? What are high energy phosphates? ATP. So basically, the stored ATPs in the tissues coming from stored creatinine stores, they get converted into ATPs, and then ATPs get used up to form ADPs and AMPs, and then adenosine. Remember, you are not supplying blood to this tissue. What is it going to do? The groceries already stored inside, they'll get used up. When they all get used up, well, then that's that. You end up having a lot of adenosine. Okay, now what's the problem with adenosine? There is a big problem. When adenosine starts to rise up in the tissues, it then comes into blood. It filters into blood. And there is no reuptake mechanism, by the way, for adenosine. So once it hits the blood, you cannot reverse it. Okay, so what's the big deal in that? In blood, your innocent adenosine converts into uric acid. And uric acid is a problem. Okay, so depletion of high energy phosphates is the very big red bull which comes in and sort of brings in the angel of death as well. All right, irreversible shock, and that's That's that. Special cases of hypovolemic shock is basically they follow all the principles of hypovolemic shock, but there are certain subtleties which you need to remember, and they can be asked very conveniently in a viva. Is what happens? What's the special status of plasma loss only hypovolemic shock? So in this hypovolemic shock, whole blood has not been lost. It's only the plasma that gets lost. How is that possible? Well, severe burns, when a person gets a lot of his body or her body burnt, red blood cells don't come out. What comes out of the damaged vessels and even the healthy vessels by the damaging of the overlying skin is plasma. Plasma basically extravasates out of the vessels, and it's lost, and the person goes into shock. And also happens in intestinal obstruction, where the site of obstruction basically raises, since it's obstructed, it raises the venous pressure such that there is pooling of blood inside the wall of the intestine. And then when there is too much pressure inside pre-venous end of the capillaries, fluid then starts to come out more of the capillaries and starts to accumulate inside the walls. And then fluid starts to be to pour out into the intestine, which is then lost through the intestine. So this is again fluid loss, which is rich in plasma proteins. Plasma proteins drop in the blood. There is further loss of fluid if you remember your Starling force as well. So again, this is a bit of a positive cycle over there. So intestinal obstruction basically can also lead to hypovolemic shock, but it's just fluid that is lost, again in burns and in obstruction, which basically really increases the blood viscosity, really increases the sluggishness. And you know what happens in sluggishness, the body is prone to develop clots, DIC. A special mention of dehydration. Don't take dehydration lightly, always be hydrated. Excessive sweating, excessive severe diarrhea or vomiting can lead to hypovolemic shock. Excessive loss of the kidneys, of the fluid by kidneys, yes. Inadequate intake of fluid and electrolytes together. So ORS is the thing to go. In Lahore, if you're residing in a place like Lahore where there's a lot of sweating in the months of the summer, only water drinking is not recommended. It's actually ORS, oral rehydration salt, or any thing which basically puts in salt and a bit of sugar in water is recommended, okay? Because that's what you lose in sweat. And destruction of renal cortices, also because of loss of aldosterone and all those very crucial hormones, catecholamines, they will add to the woes of this person, and he or she may go into hypovolemic shock. Okay, now we move on to the other types of shock, neurogenic shock, basically. And most of these shocks, basically from now onwards, neurogenic, anaphylactic, and septic shock, they are also called distributive shocks, as I mentioned before. And in this, there is no problem in the volume. Rather, the problem is in the distribution of the volume, as we'll see. So neurogenic shock basically is any damage to the brain, temporary or permanent, such as an overdose of general anesthesia, spinal anesthesia, or brain damage itself, which damages the vasomotor center of the brainstem. And as you know, vasomotor center controls the vasomotor tone of the vessels. The situation, the condition that they are in routine when the person is alive, they are not flaccid, they're not very contracted, they are somewhere in the middle. That is referred to as vasomotor tone, and it's under direct instruction from the brainstem vasomotor area. So when you have a sudden loss of vasomotor tone, what's going to happen? The vessels will give way. There will be massive vasodilation. And what's the problem with massive vasodilation? Now you can make two and two together. If there is massive vasodilation, the MSFP will drop, the venous return will drop, preload, which basically is venous return, drops, cardiac output drops, blood pressure drops. Now you come literally full 360 degree complete with the vasomotor tone. You can predict right up till the end, the arterial blood pressure will plummet, and the person will go into shock. This is one type of shock. Uh, the second is, another one is anaphylactic shock, or it's also called a histamine shock. As you have already done blood physiology, I need not discuss in detail what antigen antibody reaction is. You know it already. When antibody meets its specific antigen, all sorts of things basically gets released. Basophils and mast cells are famous for releasing histamine, and histamine is famous in these three things: increasing permeability of the capillary, dilation of all the vessels. So when there is remember, this is not a local reaction we are talking about. This is a massive antigen antibody reaction at the level of the quote unquote body. You're not talking about a localized reaction here where histamine release is actually beneficial. In this situation, histamine release is so massive that venous dilation, not just venular dilation, it's venous dilation. It's enough to bring down the venous return. Arteriolar dilation is enough to bring down the blood pressure. And increasing permeability basically leads to even hypovolemia. It can lead to hypovolemia because the blood will pour out. However, even before that, the blood pressure will plummet downwards because of decreased venous return and because of arterial dilatation. So you can imagine it's such a big shock, and you must have seen a movie or, God forbid, seen somebody go into shock while after being stung with from a bee, or inhaling something of a pollen or some other stuff which they are very, very super sensitive to, or eating something such as a new medication which even the poor chap didn't know he or she was very sensitive to. And then the choking that happens is very characteristic, and then the unconsciousness, and then it's a big medical emergency, so that the person does not go into progressive or, God forbid, irreversible stage. And so that's that. That's basically, when you see that, that is a anaphylactic shock in motion. Okay. Finally, there's septic shock. This is the most common shock in hospital admitted patients. Remember, the hypovolemic variety of shock is the most seen shock in the ER, while in the admitted patients, the most common shock is septic shock, which basically is an infection gone bad. The infection was local in one tissue or organ, localized somewhere, but then either due to mismanagement or due to aggression of the infection, it basically came to the blood. That's very bad news, because once anything is bloodborne, it is of course widely disseminated throughout the body, and then you can imagine that multiple organs will be involved. All sorts of problems of the respiration, DIC, and then MODS, which is multi-organ failure, will ensue. And it's basically an exaggerated immune response, because wherever this infection will go will also trigger an immune response. And it's characterized by fever, widespread vasodilation, high cardiac output because of hypercirculation, and DIC, as mentioned before. Before I proceed and wrap this up, there is another tricky question in Viva, which, well, I ask myself, and I've seen professors asking it as well, is if you're only allowed to, if you are told that a person is of a patient of shock, and you're only allowed to touch the skin of the patient and try to guess which type of shock it is, how can you tell? So this is where the warm versus cold shock concept comes in. Cold shock is, okay, let me see how many of you get this correct. Again, you can use the comment section below to tell me which is an example of a cold shock, and which are the examples of warm shock. I'll wait for your response, and then of course give you the answer, inshallah. So this is that. Lastly, complications of shock are basically the main complications of all of the shocks together. Mainly there are septic shocks, septic shock complications, but it can happen in any types of shock. Okay, we have discussed most of them, and this basically concludes this lecture. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.